Hello friends, let us continue our lecture on mitral stenosis. I would highly recommend you to watch the previous lecture for better understanding, because all the diagrams which I am going to use now are drawn and explained clearly in the previous lecture. So now let us learn about the clinical features and the investigation findings which we see in mitral stenosis. Okay, clinically the patient with mitral stenosis comes to us with, as I have said, why. The question why is truly important here. So, okay, I'll take one more color pen. Okay, so I'm using pink for all the clinical features. Okay, and why? First, as I have said, because of all this diagram, please refer to the past section. So here there is, in the lungs, there is pulmonary hypertension. So because of the pulmonary hypertension in the lungs, the patient will come to us first. There is dyspnea, because there is pulmonary hypertension and there is back pressure. There is impaired exchange of gases here, because alveolar exudate is there in the alveoli. So as a result, there is number one, dyspnea. The patient comes to us with dyspnea, and then the patient also comes to us with hemoptysis. Here, because of the pulmonary hypertension, the vessels which are there here, because there is vasoconstriction, as I said, because of that there is rupture of vessels. So because of the rupture of vessels, the person may have hemoptysis. So hemoptysis is also common in these patients. And now, the patient may also come with palpitations history or arrhythmias. Why is there an arrhythmia? I didn't explain this in my last class. Arrhythmia is most commonly atrial fibrillation. Among the arrhythmias, the most common arrhythmia which we see in mitral stenosis is atrial fibrillation. The question is why? The main reason of my atrial fibrillation is, here if you see, the left atria has been enlarged. Okay, for time being, if it's mild, because of left atrial enlarged, there is left atrial enlargement is more when compared to right atrium, right? So because of enlargement of left atrium is more, and it has to work with this mitral valve to open. So as a result, the left atrium, the impulses impulses normally travels from the sinoatrial node to AV node to bundle of his, then right bundle branch, left bundle branch, and then to the ventricles wall. So now the AV node from sinoatrium, the sinoatrium sends its impulses. So from sinoatrium, the impulses reaches the AV node in the right atrium very fast, because it has mild enlargement. Whereas right atrium, it has large enlargement. It has enlarged a lot. Just let me show you by a small diagram. Okay, so if this is the atrium, so the right atrium is enlarged lot. Sorry, left atrium is enlarged lot. Right atrium is mildly enlarged. The left ventricle is normal. Right ventricle is little enlarged. So now it's just a hypothetical diagram. Okay, so now if this is the impulse which is here from SA node, I'll draw it with other pen. Yeah. The impulse which is there in the SA node, this is AV node. Okay, this is bundle of his, and then right branch and left branch, and then Purkinje fibers. Okay, now the impulse from the SA node to AV node in the right atrium, it will flow very well. But in the left atrium, if you see, it has reached the left atrium. Left atrium, it is very large. So there is delay in the impulse to come. And sometimes because of this delay, the impulse may travel haphazardly. So this traveling of impulse haphazardly, this can lead to arrhythmias. And most common arrhythmia that you see, it is in atria, and there is abnormal firing. So that is atrial fibrillation is seen. Okay, so this is the major arrhythmia. So these arrhythmia, the patient can also come with palpitations because of this atrial fibrillation. So because of this atrial fibrillation, the person may have palpitations. Okay, so these are the major symptoms with which the patient comes. And then what are the signs of this atrial fibrillation. Sorry, what are the signs of this mitral stenosis? So the first sign, as I have said here, there is increased back pressure from the right atrium to the superior vena cava and also inferior vena cava. So the patient can come to us with malar flush. Okay, why malar flush? Because of the because the veins in the neck are unable to empty in the superior vena cava. So the veins of the neck are distended. So because of the distension of veins of the neck, the whole veins from the face, they are not able to empty into the veins of the neck. So as a result, the facial veins are distended and they undergo arteriovenous anastomosis. So that arteriovenous anastomosis, because it has deoxygenated blood, it looks as bluish appearance in the cheek. So that is called as malar flush. Okay. Now, that is one. And here neck veins are distended. So you can see JVP. There is pulmonary hypertension also. So here we see JVP. Once we see JVP shows because mostly atria are involved. That too left atria is involved. So there is prominent A waves. The others are normal. So there is prominent A waves. So this we see in JVP. Okay. Then when you percuss the heart, you can see and you can find enlarged right ventricle. Okay, it is really difficult to do so, but generally we can find the enlarged left ventricle. Okay, enlarged right ventricle. Left ventricle is absolutely normal. You can see even in the diagram, left ventricle is not at all affected at all. Only the right atrium, right ventricle and left atria are affected. Now, what are you going to see on auscultation? I have already discussed why each murmur occurs. I have discussed in my last class. Please refer to the last class for better understanding. So, first there will be, I'll draw it again here so that it becomes easier for you. Okay. So, there will be S1 and S2. This is again S1. So, this is systole, this is diastole. So, in the diastole there are three parts. One is early first rapid filling and then diastasis, then second rapid filling. So here there is flow of blood normally, and here there is first there is a systolic snap because of the opening of the mitral valve, and then there is mid diastolic murmur which increases and decreases in intensity. Okay, and then the atria contracts at the end of the diastole, that is second rapid filling phase, and because of the atrial contraction there is pre-systolic accentuation again. So here you have three different things. One, you have systolic click, you have click, and then you have mid diastolic murmur, and then you have pre-systolic accentuation. Okay, this is what you see. And then there is one more thing. Because of this back pressure, there are two regurgitations can occur. One, pulmonary regurgitation, and then tricuspid regurgitation. How and why, please refer to the last class. If you could not understand, then please comment it in the comment section. I'll explain again. So, because of pulmonary regurgitation in the S2, in the systole, in the diastole, because of pulmonary regurgitation in the diastole, you will have a murmur which is Graham-Steele murmur. Whereas in the systole, pansystolic murmur is seen because of the tricuspid regurgitation. So, what are the components? One, if there is tricuspid regurgitation, there is pansystolic murmur. Okay, there is early diastolic murmur. If there is pulmonary high regurgitation, this is because of pulmonary regurgitation, and there is a click is there, and then there is a mid diastolic murmur, and then finally there is pre-systolic accentuation. These are due to mitral stenosis. All of these can be present or only a few can be present. Okay. As the severity of the disease advances, the open snap. It's not click, open snap. I'm sorry, it's an open snap. This open snap will move towards the S2. And in severe cases, if there is very severe cases, in such case, you will not see the click at all, because the click will occur simultaneously along with S2. So there is like this, and the duration of the murmur increases. Even the pre-systolic accentuation is also lost in the severe cases. In the severe case, you will only see a complete pan-diastolic murmur. Okay. So this is what you see on examination. Now, what investigations are you going to do for mitral stenosis? All the investigations we will learn in our next class. So thank you guys for watching my lecture. If you have any doubts, please comment in the comment section. I'll definitely try to answer it. And thank you for watching my lecture. Thank you. Please subscribe the channel for more lectures. Thank you.